Okay, let's continue for now. We have to speak a little bit more about diagnosis of an MI. So, someone has an MI. How can I deal with it? What should I do? How is it going to be? What is my initial steps? So, someone comes to you with a chest pain. What do you do first? ECG or enzymes? Yes, you start with an ECG, never enzymes first. ECG is first. So they write for you, in the first 6 hours, ECG is the gold standard. And cardiac, why? Because cardiac troponin I rises after 4 hours and peak in 24 hours. And also is increased for 7 to 10 days. This is important. Why? Because let's imagine that the person got infarction at the first day and his troponin jumped up. And he got a reinfarction, let's say, on the third day. If you check the troponin, well, if he had a reinfarction or not, it will still be high. So you have to check the CKMB. Why? Because CKMB rises high and then go back low really, really quick. So it goes high quick, go down quick. So you can see here the following. They write for us. Cardiac troponin I rises after 4 hours, peaks at 24 hours, and is increased for 7 to 10 days. It's more specific than other protein markers though. While if we speak about the CKMB, it rises after 6 to 12 hours, yeah? And peaks at only like 24 hours and then jump back down. So if the patient gets a reinfarction, it seems more logical to use CKMB to diagnose him, not troponin. Okay, so the next thing here we have is the following. They write for us that this CKMB is predominantly found in the myocardium but can be released from skeletal muscle. But which serotype is most likely to be secreted from skeletal muscles? Can someone tell me? CKMM. Yes, CKMM is the correct answer. Okay, so it's useful in diagnosing reinfarction following an acute MI. Why? Because the levels return to normal after 48 hours, and thus you can check the reinfarction much more easily. While in troponin, it will be high anyway. You know, reinfarction or not, it will be high because the half-life of it is much more longer than for CKMB. Large MIs can lead to a greater elevation in troponin I and CKMB. Exact curves vary with testing procedure, so you cannot tell according to the level of how high it is, if it's like a new infarction or not. So the next thing, ECG changes can include ST segment elevation myocardial infarction, which will lead to a STEMI, transmural infarct. We spoke about this. And it can be an ST segment depression myocardial infarction. It's due to subendocardial infarction. And we also spoke about this. It was the last area to be supplied. And next we have, they tell you in the hyperacute state, the T wave will be peaked. You can also have T-wave inversion. I remember a lot of students always have this difficulty, be like, this thing is confusing. How the T-wave can be peaked and be inverted at the same time? The answer is with a question. The question is when. So if you write myocardial infarction ECG progression, you will see the following. Well, initially, it's true that you have a peaking of the T wave. See, it's a peak T wave. Here it is, it's peaking. But after some times, you have this ST segment elevation, blah, 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 and then T wave inversion. So minutes after the MI, you will have a peak T wave. Days after the MIs, you will have T wave inversion. I hope it makes sense. Again, peak T wave inversion. Big T wave inversion. Big T wave means what? Acute. Inverted means happening after multiple days you are checking the ECG. Okay, so here they write a hyperacute will have a big T wave inversion, a new left bundle branch block, and a pathological Q wave, which we have seen, or poor R wave progression, evolving or all the transmural infarct. Let me ask you the following. The first question goes something like this. In left bundle branch block, where will be the bunny ears? Will they be in V1 or V6? V6, good. In right bundle branch block, V1, V6? Good. In case of, in case of this pathological Q thing, if we say that the patient has this pathological Q, this pathological Q, will it be appearing after the MI has finished or not? Yes, like, I mean, he got the MI and 3 years later you are looking at his ECG. Will you see that Q wave? Yes, the answer is yes. Even after so many years, you will be able, yes, forever. Yeah, I told that to my ex. I will be your Q wave. Be there forever. So, next thing, R wave progression. So the R wave progression, it's evolving or an old transmural infarction. What does that mean? Guys, if you have a necrotic tissue that has scarred, it will not be able to contract anymore. And the contraction creates the R wave. If you cannot contract anymore or you contract less, the R wave will be less long. It will not be the same. Okay, now the localization of an MI. This is super important topic, really, really important. Let me take, yes, low voltage. So let me take a moment on this because this is super important topic. You know, guys, that we have, how many bipolar lead do we have? Bipolar. Yes, we have 3 bipolar lead. Bipolar means that each lead has 2 leads inside of it. So if I'm taking the heart here and putting the heart at here, let's imagine the heart is here. And this is the axis of the heart. And at this area, here you have 1 lead, bipolar lead, another bipolar lead, and another bipolar lead. So here it goes like lead 1, 2, and 3. Okay? In the same time, here it goes AVR, AVL, AVF. So each lead contains 2 leads inside of it. How many chest leads do you have? 6. Keep in mind that 3 of these are looking at the chest anteriorly, while 3 of these are looking at the chest laterally. Yeah? That, and if you remember the heart, what was the anterior-most chamber of the heart? Right ventricle. So inside of the right ventricle, do you have the right bundle branch block appearing or the left bundle branch block appearing? Yes, that's why in right bundle branch block you will see it at V1. This is V1, guys. Okay? While in the left bundle branch block, what is looking at your lateral ventricle? It's V6. That's why the bunny ears are there. Okay? I hope it makes sense. Okay, if it does not, it's okay. I'm going to explain it later. But here is the idea. So you have 6 chest lead. You have V1, V2, V3, V4, V5, V6. Okay, so these 3 are looking at the heart anteriorly. These ones are looking at the heart laterally. Let's take a look at the heart. So here we have anteroseptal leads. They are looking at the heart anteriorly from here. As you can see, it's like V1, V2. They are looking at it anteriorly. Yep. Okay, so what about the next one? Well, this was the anteroseptal. They are looking at the septum of the heart. While the anteroapical, they are looking at the tip, the apex of the heart. That's V3, V4. Anterolateral 1 and left circumflux, they are looking at the lateral wall. obviously, so that will be V5, V6, in addition to the lead 1 and AVL. Why? 1 AVL, sorry, I made a mistake here. Here is supposed to be 1, here is supposed to be 2. Okay, so 1 AVL, they are located at where? They are located here. While if we speak about the lead 2, 3 AVL, they are related to the inferior. Well guys, if I speak about the inferior wall of the heart, which ventricle is the inferior wall of the heart made out of? The inferior wall of the heart is made out from which ventricle? Well, they tell you that it's supplied by the right coronary artery. If it will be supplied by the right coronary artery, which ventricle it's going to be? The right ventricle. So you are like, wait, but you told us that the right ventricle is the anterior most chamber of the heart. How come you now tell us that it is the inferior chamber of the heart? Well, in reality, it's like this, guys. If you look at it inside of the heart, it is like anterior and inferior. So this is the right ventricle, this is the left ventricle, the atria is the most posterior one, but the right ventricle makes the anterior wall and the inferior wall. You must know this. So if I tell you an inferior MI, it's the same as telling you it's a right ventricular MI. There is also, it's possible to have a posterior MI. You must know one thing about posterior MI, that you have to suspect it how. You look at the reciprocal lead. What is the reciprocal lead? For example, if someone has an ST segment elevation in V1 and V2, he will have an ST segment depression in V6 and V5. Yep. So now you can imagine why in this area versus this area, if you have an affection of the heart from one area like ST segment here, in the opposite area it will be elevation. Okay, so they are vice versa. Well, if in the posterior, if the patient has a posterior MI, good, he has a posterior MI. We never put the V7, V8, V9 normally. We put it only if we suspect a posterior MI. How can I suspect a posterior MI? Well, if the V1, 2, 3, see V1, 2, 3, the anterior one, are showing you ST segment depression, you need to do the V7, 8, and 9, which are located here in the back, to tell you that, oh, they can be having an ST segment elevation on the posterior lead. Because anteriorly, they show depression. Posteriorly, they will show elevation. Yeah? So the reciprocal lead show reciprocal cardiac activity as well. So if you have an ST segment elevation of your anterior lead, you will have an ST segment elevation in your posterior lead. Okay, so how does V7, V8, V9 look like? It just leads that you continue to add them on the back. That's it. So let's speak about the heart ECG. I like this one, but there is one that I like more. So let me show you the one that I like more. Okay. ECG. Yes, so the one that I like more is actually this one. Why I like it more? Because it has a like visual representation of where each lead is located. So let me just send this to the group. If you take a look at this one, guys, it has a lot of things that you can appreciate. The first thing that you can appreciate in this picture is that the aorta, they put it near the AVR. Why? Because AVR mostly, it's not a lead that we look at. It's a lead that we look at just to make sure we did not mess up like putting it in the correct place, you know? Because when you look at it, the R wave is supposed to be going down, the B wave is supposed to be going down, and the T wave is supposed to be going down. Notice, B wave down, R wave down, and T wave down, which means it has put in a correct place. That was the first step of the algorithm, if you remember. So from the aorta, you have the lateral anterior descending artery. And your V1, V2, 3, 4, all of these are a representation of your LAD, lateral anterior descending artery. So if you have an occlusion of this, you will have an total occlusion of this. You will have an ST segment elevation in V1, 2, 3, and 4. To make it more interesting, guys, the left circumflux comes out from the LAD. So if the infarction is proximal to this, you will also have an ST segment elevation in V5, 6, 1, and AVL. Let's imagine that someone had the occlusion here, distal to the left circumflux. He will have ST segment elevation in which two leads? Write me, please. If the occlusion was here, where the ST segment elevation will occur? It's not, the occlusion is not at the left circumflux, the occlusion is just here. So it will be at V2, V3, because V2, V3 are supplied by this one. So if you have occlusion of this guy, the ST segment elevation will be at V2 and V3 only. If someone has an occlusion of left circumflux itself, like here, he will have an ST segment elevation of what and what and what and what? If you occlude, okay, so 1 AVL, what else? And 5 and 6, exactly, V5, V6, lead 1 and AVL. Awesome. Okay, so if someone has the main left coronary artery occlusion, it will be from V1 until V6 in addition to lead 1 and AVL. While in the right coronary artery, you can see it's only the RCA only supplies lead 2, 3 AVF, which also represents inferior MI. If I tell you lateral MI, it's supplied by the left circumflux. So the patient left circumflux and what also? Left circumflux in addition to V4 and V3 and V2. So this will have the ST segment elevation. Okay? If it was solely LCX, it will be going like this. I hope it makes sense. So it's according to which coronary artery is affected, you will have the ST segment elevation at that exact artery. Okay? So let's go back to first aid and see what they draw for us. It's the same thing, but it's different graph. So this is a normal ECG. The bipolar lead are these three. Yeah? Like bipolar, so they have two inside of them. And if we speak about, first of all, this lead, these are the anteroseptal lead, as you can see. They are looking at the septum of the heart. While the V3, V4, they are looking like at what? The apex of the heart. These leads, like V5, V6, 1 and AVL, are looking at the lateral portion of your heart. So you can see them looking laterally at the heart, looking laterally at the heart. Well, lastly, lead 2, 3 AVF, they are looking what? Inferiorly at the heart, at the lower border of your heart. So this is important. Why? Because now you can look at an ECG and know exactly on an angiography which vessel you need to approach, where exactly is the infarction, and which vessel you must revascularize. So if you see that the patient have like an ST segment elevation and lead 2, 3 AVF, it means that he has an inferior MI. Which vessel is affected? Tell me, please. In case of inferior MI, lead 2, 3 AVF, the RCA is the vessel affected. Excellent. While if, for example, I give you like an ST segment elevation and lead V1, 2, 3, 4, 5, 6, 1 AVL, which vessel is occluded? The LAD, exactly, the common LAD, the main thing, the left main coronary artery. Okay, awesome. So I hope that made sense. We will be doing many cases on these, so I need you to be comfortable with them. So when we will do the cases, it will be like a piece of cake for you. Let's just speak about a little bit more about this, and that will be it for the day. Let's speak about myocardial infarction. I wanted to explain for you cardiomyopathies, but this is just a lot for one day. It's like impossible for you guys to retain all of that in one day. It's not fair. So let's do the myocardial infarction complication. So speaking of the complication, remember the most common cause of death in the first 24 hours after an infarction was what? Ventricular arrhythmias. So cardiac arrhythmia, it occurs within the first few days after an MI. And it's important cause of death, sudden cardiac death, before even reaching the hospital. And within the first 24 hours, post MI. So some person get an MI, 24 hours, he's gone. What has happened? Well, he got an arrhythmia. That's it. Okay, so the next one is post-infarction fibrinous pericarditis. He will have the friction rub. It occurs between 1 to 3 days. It's secondary to the acute inflammation, which happens secondary to the necrosis, because necrosis always is followed by acute inflammation. Now your question, guys. Can you please tell me? It will happen in a transmural. Yes, we spoke about this. Yeah. It happens in the transmural one, or does it happen in the subendocardial one? Which one does it occur in? Exactly, only the transmural one. It cannot happen in the subendocardial, because this one, pathogenesis, is just an extension of the inflammation. That's it. Okay, the next one, it's about the papillary muscle rupture. So the papillary muscle rupture occurs between 2 to 7 days. So why it occurs? Yes, listen. Macrophages. I was going to ask about this. Macrophages do it because they eat the muscle. So which muscle are they eating? They are eating the papillary muscle. Okay, now they write here really important thing. Why the posterior medial papillary muscle is at higher risk of getting affected than the anterolateral one? Why posterior medial papillary muscle is more likely to be affected by rupture than the anteromedial one? Yes, it's a single blood supply. That's the idea. So the posterior medial one only has a blood supply from the PDA. That's it, posterior descending artery. While if you speak about the anterolateral one, it has a blood supply from the left circumflux in addition to the LAD. So 2 in 1. So you can see that if you have 2 blood supply, you are, okay, you might occlude one. You can occlude 2, it's possible, but it's more rare, you know. But overall, it's enough to occlude one, it's enough to occlude the PDA, and you will get posterior medial papillary muscle MI. Okay, they can result in a severe mitral regurg. You told me that that was a systolic or diastolic murmur. I forgot. Oh yeah, it was horisystolic, correct. So the next thing is intraventricular septal rupture. Since it's in a septal rupture, there is something eating. So which organelle? Who likes to do num num num? Macrophages, yeah. So remember, macrophages like to come between 3 to 5 days. So it's a macrophage mediated degradation. So the patient will have a VSD, ventricular septal defect. If he has a VSD, will he have left to right shunt or right to left shunt? Left to right, correct. So there will be more O2 saturation and pressure in the right ventricle. If you remember, guys, I used to give you this question. Just I'm going to give you one of them really quick. So I used to tell you about this question about different pressure inside of your heart. So normally we know that in the left atrium it's like less than 12. Left ventricle it's like 120/10. And in the aorta it must be like 120/80. Here it's 5, here is 5/25, and here is like 10/25. So, and if we speak about like the O2 sat, and I tell you something like this, in the blue I will give you the O2 sat. If I tell you it was 70% here and 70% here, and then here suddenly it jumped to 90%, and here it stay 90%, and here it becomes like 99%, and here it's 99%, and here it's 99%. What does this patient suffer from? VSD, exactly, because there was passage of this oxygenated blood through a VSD from the left ventricle to the left atrium. What will happen to the pressure inside of the right atrium in such case? Mostly nothing, guys. You must know this. It's mostly nothing. Why? Because there is a valve. Valve allows the passage of blood only to one area, not the other area. So the pressure will be kind of the same. It will not be altered. But the pressure here inside of the right ventricle will be increased significantly. Right atrium, nothing. Right ventricle, yes, it will be increased significantly. What about the pulmonary artery? Increased significantly. Okay, if I give you the same question, but instead of telling you, I tell you that this become 99, 99, and here it jumped from 70 to 99. What is the problem? ASD, excellent. And if the same deal, and then I tell you like it was 70, and another time 70, another time 70, and here it comes 99. What the patient suffer from? Yes, it's a BDA, excellent. Okay, so let's go back here. So interventricular septal rupture, the patient has, it occurs between 3 to 5 days. Macrophage mediated degradation, VSD, increased O2, SAT, and pressure in the right ventricle. Okay, so the next thing you must know, it's including like complication as well. Ventricular pseudoaneurysm. Guys, is ventricular pseudoaneurysm a complication of the scarring or a complication of the macrophages eating the heart? Macrophages, yeah. Okay, is ventricular true aneurysm a complication of macrophages or a complication of scarring? Yes, it's a complication of scarring, that one. Okay. Ventricular pseudoaneurysm formation, it occurs between 3 to 14 days because, as you said, it was the macrophages. So the patient might suffer from free wall rupture, but it will be contained by an adherent pericardium or scar tissue, as you can see in this picture. Yep, this one. Okay, let's go down there. Oh, the exact same picture is here. You can see it here. And here you can see like the papillary muscle rupture. Okay, so that was ventricular pseudoaneurysm. Also, rarely, okay, important thing about this one. Ventricular pseudoaneurysm formation, you can imagine the amount of the blood inside of your left ventricle will be reduced. So that leads to decreased cardiac output. In addition, you have risk of arrhythmia. Also, you can have an emboli or a mural thrombus. But which one between a true or pseudo aneurysm have higher risk of thrombosis? Is it the pseudo or is it the true? In a true. While which one between the two have highest risk of tearing? The pseudo. Excellent. Okay. So here they write for us that ventricular pseudoaneurysm, blah, 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 it has risk of arrhythmia as well because it can like play with your conduction system. So ventricular free wall rupture, is it due to macrophages, neutrophils, acute inflammation, or scarring? Write me. Macrophages, they are the people who like to eat the most. So it's due to macrophages. It's 5 to 14 days, a free wall rupture, and it can lead to cardiac tamponade, which is blood around the heart, as we saw in the picture I drew for you. The patient might be suffering from left ventricular hypertrophy and the previous MI protect against free wall rupture. You are like, what the toot? Why does a previous MI protect me from having free wall rupture? It does not make sense. Well, if you had a free MI before, what will happen at that area? There will be scar formation. Yeah, guys? So, is a scar formation made out of fibrous tissue or cardiomyocyte? Fibrous tissue. The fibrous tissue can be quite thick, and that for the macrophages to go and eat a cardiomyocyte is not a big of a deal. But to eat an unliving thing, which is a fibrous tissue, it's quite difficult. Yeah? It's like eating the bone of a dead animal. It's impossible. You know, it's difficult. So to get a ventricular free wall rupture in a second MI is quite rare because of the fibrous tissue and the formation of the scarring. But to get one in a first time myocardial infarction is more common. Okay, if the free wall rupture happens acutely, the patient is dead. That's the interesting thing. It's almost you will never see a patient with this, but the pathologist will see all of them. Okay, so free wall rupture, done. Okay, true ventricular aneurysm. So we said this one is due to the scarring, you told me. It's 2 weeks to several months afterward. And there is an outward bulge with contraction. Why? Because the wall is dilated. That is correct, but he is like a flab. You can see. It's dilated, but he's like a flab. It's not contracting. Since he is like a flab and he's not contracting, he's useless. He's dyskinetic, which is like disturbance of movement. And it's highly associated with fibrosis and thrombosis. It can predispose to thrombosis and thromboemboli, which can predispose to strokes. You must know about this. The other complication we have is Dressler syndrome. Really important. You must know that it's an autoimmune phenomena. And my question for you is it associated with a transmural or subendocardial myocardial infarction? Both. But if it was occurring 1 to 3 days after the infarction, it will be only the subendocardial one. If it is occurring late, like after 2 weeks, it means that it's autoimmune, like it's due to the Dressler syndrome. Remember, in Dressler syndrome, your immune system is just like taking a look at this MI, like the scar tissue. He's like eating a little bit of it, presenting it, antigen presenting cells presented, make you some antibodies. That antibodies go to the chest, and that lead to Dressler syndrome. Someone write if a few days later it's a transmural, no? Well, here is the thing. If it's a few days later and you have pericarditis, it will be a transmural MI. It must be, because it cannot be subendocardial, you know? Let me make an association for you. If some person have an ST segment elevation myocardial infarction, 3 days later, he has like a pericardial friction rub, okay? So, and the question says, the infarction he has, is it subendocardial or transmural? It's transmural. Yep, good. So, next, okay, someone has an ST segment depression, myocardial infarction, and 3 weeks later, he presents with you with a friction rub, chest pain on inspiration. What's up with him? It's a Dressler. How do you treat both of these? It cannot be both in this case, because I just told you it's subendocardial. So it's the I told you that it's a ST segment depression. ST segment depression is associated with subendocardial. Good. So, okay, you treat both of them with NSAIDs. Just keep that in the back of your head. Do not give cortisol. It's not the initial step. At least for the USMLEs, you must know that it's mostly NSAIDs. Then you give colchicine. And if both of these don't work, you can give the steroid. But for the USMLE, they like the NSAIDs. Okay, left ventricular failure and pulmonary edema. So, if infarcted tissue does not contract. So, left ventricular failure can be secondary to left ventricular infarction, also VSD leading to a high cardiac output MI, and also due to free wall rupture, creating a tamponade. Also in case of what? Papillary muscle rupture with mitral regurg, which we spoke about. So yeah, all of these can lead to left heart failure, and they can lead to pulmonary edema. How can you diagnose pulmonary edema with your stethoscope? What do you hear? What do you hear over the lung in case of pulmonary edema? Basilar crackles, exactly. Good. So that's what you are going to hear, basilar crackles. So when you put the stethoscope at the lower portion of your patient back, you will be able to hear crackles. Okay. Crackles, remember, crackles are in the alveoles. Wheezing is in the bronchi. Okay, acute coronary syndrome treatment. So, guys, it's written here in a weird way. In step 2, they gave us like an easier way to deal with it. So I'm going to give you the one for step 2 because it's easier to read than this one. It says something like monobash. Okay, so what is this monobash? So this monobash mnemonic, I love it personally because it makes life easy. It's this thing. So let me send it to the group, just a sec. Where are you guys? So the monobash goes something like this. You need to give the person morphine. It does not improve the mortality, it just makes him feel good about himself. I'm kidding. We give it because of the pain. MIs are painful. The same with oxygen and nitrate. Aspirin, on the other hand, we give it because it improves the mortality risk. Beta blocker, why would I give a beta blocker for someone with a dysfunctional heart? Because it decreases the amount of O2 demand of the heart. ACE inhibitor, you can give it a little bit later. The main idea is to decrease the blood pressure and decrease the afterload. Statin, you can give it a little bit later, not acutely, to reduce the risk of atherosclerosis progression. And finally, heparin, which help to resolve the clot. Keep in mind that the main idea for you that I apologize, I did one thing wrong. So aspirin prevent further aggregation. Heparin stabilize the clot and prevent it from becoming worse, and actually can a little bit help with its resolution. But what really help with its resolution is fibrinolytics, like Altibase, which we'll speak about in the future. So here we have unstable angina and STEMI. So non-STEMI and STEMI. So what do I do in case of non-STEMI? Anticoagulant like heparin, antiplatelet drug like aspirin, ADP receptor inhibitor like clopidogrel, and sometimes we give both of them, like two different mechanisms of action, but they have synergism, which means when you give the two drugs, the sum effect is higher from giving either of them alone. Beta blockers, you must know that we give it due to fact of decrease the O2 demand of the heart. ACE inhibitor to decrease the afterload and the preload. Statin to improve the to prevent the formation of atherosclerosis. And symptoms control, as you see, these two are not for the treatment, it's just to make the patient feel better. The oxygen, the morphine, and nitroglycerin. These three is to make the patient feel better. In the other hand, STEMI, we give all of these, but you must do the reperfusion therapy. There is two ways to do reperfusion therapy. It's either chemical or mechanical. The mechanical one is percutaneous coronary intervention, which is basically you put a catheter inside of the patient femoral artery or radial artery in his hand, and you push it all the way to the coronary artery in his chest. You are like, do you mean we push it like 2 meters inside of the patient? Exactly. Until we open his coronary artery inside of his chest. If that is impossible, it will be the fibrinolytics if you don't have such thing in your yes. So you have to give fibrinolytic if you don't have a catheterization lab in your hospital. Guys, there is one question you must know about. Some person just mentioned it, and it's super high yield to know it. So, look, in case of right heart MI, okay, right heart MI, is there more blood going to the left ventricle or less? Less. So that decreases the preload of the left heart, correct? And if you have less preload to the left heart, The heart feels good, and well, the heart is initially there is less stress on the left ventricle. But if I give the patient nitroglycerin, what will happen to the preload in the left heart? Less or high with nitroglycerin? Less. So the patient with right heart MI already have a less preload in his left ventricle, and you are giving him nitroglycerin, which is exacerbating his left ventricle, his right ventricle MI by decreasing the preload even more. So you will have significantly low preload, which will decrease your cardiac output significantly, which can itself lead to ischemia of your heart. So you never give nitroglycerin on case of right heart myocardial infarction. To make it more easy for you to know if it's a right heart infarction or a left heart infarction on the scene, like let's say you are not in a hospital and you are in kind of a rush, you don't know, you want to give the nitroglycerin to make the patient feels better. So you think about, okay, should I give him the nitroglycerin or not? Check his blood pressure. If the blood pressure is significantly low, that means he has right heart failure. If it's normal or high, it's left heart myocardial infarction. Give him the statin. So low blood pressure, do not give him the statin. High blood pressure, oh, what statin? Sorry, nitroglycerin. Low blood pressure, do not give the nitroglycerin. High blood pressure, give the nitroglycerin. Why statin? Statin is super important because why the statin? Because they prevent, it's a little bit later actually, you don't have to give it immediately, but it's to prevent further atherosclerosis. You don't want that atherosclerosis to become bigger, because if it becomes bigger, it can lead to further occlusion. That will suck, you know, so we don't want that. And that's it for MIs. Tomorrow, today, for some of you, tomorrow for some of you, I will be posting many cases on the other group. You know how it goes, like every single day we do this. On the other group, I will be posting a lot of ECGs. You must take a look at, you must diagnose, and in addition, I will be posting some of these complications. Tomorrow we will do quite a few ECGs. I prepared a few ECGs for you, and we will be doing them together tomorrow. And after that, we'll continue with the cardiomyopathy and we will move on. And that's it for today. We did the 3 hours. It was a fun session and I hope you liked it. For the new members, I hope you join us, guys. Otherwise, see you tomorrow. Bye-bye.